The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Now, before we get started, I'd like to introduce our speaker. Professor David Beversdorf is currently involved in research on autism, dementia, cognitive effects of stress, the cognitive neuroscience of problem-solving ability, functional neuroimaging, and pharmacological modulation of cognition. His work has been published in journals such as Neurology, the Journal of Neurology, Neurosurgery, and Psychiatry, Proceedings of the National Academy of Sciences of the United States, and Lancet. Dr. Beversdorf is the William and Nancy Thompson Endowed Chair in Radiology at the University of Missouri. These webinars are made possible through generous donor support. If you'd like to contribute, please visit our website at autism.com. And now I will turn this over to Dr. Beversdorf.
Hi, thanks for joining us. I'm excited to present this to the Autism Research Institute, and because it's the Autism Research Institute, I'm going to get right into the talk and dispense with the formalities of the This is Autism slide, so hopefully that's okay with everybody. But the focus that we're talking about is treatment. Now, early diagnosis and early behavioral intervention, they're the best thing we've got right now. They are the most impactful thing we can do, and all of us pharmacology folks are flailing around and trying, but we've got a long way to go. The things we have now are targeted to symptomatic treatment. So just like anyone else, we can treat anxiety, we can treat aggression, we can treat obsessiveness, we can treat depression or ADHD in the autism setting, in the ASD setting, just like we do with anybody else. The most common thing that we see different is that there's a very idiosyncratic response in the autism population, and that some will really not do well with a drug, and others will do great. And it's hard to predict who's going to be who. But there are only two drugs that are FDA approved for autism: aripiprazole and risperidone. These are atypical neuroleptics. So they come with all the risks of atypical neuroleptics, the cardiovascular risks, the sugar risks, the weight gain, and they're targeting behavioral disturbances, of course. So they aren't really targeting the core features of autism. We don't have anything at this point for core or cognitive features of autism. There are a number of things that are being tried, and the jury's still out. One of the big ones for a long time has been oxytocin. I won't go too heavy into all the different things, but on a few ones. Oxytocin was very interesting because of the mountain voles and the prairie voles. One group was very social and interacted with the other was loners. The big difference was oxytocin and vasopressin, and they found that this actually could change one group to the other depending on the manipulation. Of course, that social interaction factor became of great interest to autism, and this is how we get things in the pipeline. But the jury's still out on this. Some studies have been positive, some less so. We need some bigger studies to sort this out. Several case series that initially looked at Alzheimer drugs, including cholinesterase inhibitors and NMDA antagonists. Cholinesterase inhibitors increased the availability of acetylcholine. There was some modest benefit, but they also have some side effects with it. So the NMDA antagonists became of more interest. And one of the big reasons is the excitatory to inhibitory imbalance associated with autism. Lots of postmortem studies have looked at GABA and glutamatergic changes in autism and autism spectrum disorders, and have found hyperexcitability or low inhibition. And so the NMDA antagonists would block the excitatory glutamate system, and GABA agonists would activate the inhibitory GABA system. So trials of memantine and NMDA antagonists were done, and GABA agonists, arbaclofen, were done, but these both failed to reach their primary outcome measures. For the FDA, you have to pick one measure as your primary outcome. It didn't reach that. Now, the GABA agonist studies were done by a group that was more open about the data, and they've shared a few things with us. First off, some secondary measures did look more promising, but the big thing that that wasn't publicly available at that stage was that there seemed to be a subset of individuals that did respond very, very well to this medication, but when you put everybody together, it didn't come out in the wash, at least for the primary outcome measure. That heterogeneity or individual difference in response, I think is something that's going to be very, very important as we all move forward, and I will wrap back around to that at the end of our talk a little bit. But there are many other agents that have been used, but I'm going to focus on one in particular that did not get a lot of attention initially. It was a case series in 1987 that was published showing a small series of patients that were given this medication. It was not a controlled trial. It was just monitoring how they did after trying the drug and titrating it up. And they tracked social and language outcomes and is mostly a descriptive study, and they shared benefit in that set of patients. And what was really interesting to me was now this drug, Propranolol, it blocks the norepinephrine system in the brain. That's the basic your fight or flight reflex in the brain system. It was originally developed in the 60s for blood pressure and heart rate control, but it's been used for a myriad of other conditions, ranging from migraine to infantile hemangiomas to preventing a second heart attack. But the thing that got my interest is that it has been used for decades for test anxiety and performance anxiety and public speaking anxiety. And the performance anxiety is sufficiently prominent of effect that my mother-in-law, who recently retired from the Seattle Symphony, said that people were auditioning on this medication right and left. Now, my original interest in this, actually, this is how the science kind of evolves, actually came from a study with a dopamine drug. There was a study that looked at semantic priming. So if I show you the word summer, you'll recognize the word winter more quickly than any other random word like ladder, because I've primed it with the word summer. Now, in the placebo condition in that study about 20 years ago, they also primed 2 steps away from summer, winter, snow. You'd recognize the word snow more quickly. Now, if I gave you the L-DOPA beforehand, you no longer primed the word snow more quickly. They thought this was a restriction of the semantic network resulting from this. And I thought, well, maybe this applies to problem solving too. And began to think about the pharmacology of L-DOPA. And while L-DOPA is converted into dopamine, it is also converted downstream to norepinephrine. And I thought about it a while and thought, well, Parkinson's patients, they're not amazing problem solvers. Doesn't really seem to have a bearing there, at least not a beneficial effect. So maybe this is all due to norepinephrine. Well, it turns out we did a number of studies, and turns out the priming effect was in fact due to dopamine. The norepinephrine drugs had nothing to do with this, but there was an effect that was very interesting on the problem-solving side of things with the norepinephrine system. So moving right into this, we wanted to look to see if this is something fundamental that goes on in the brains of people that aren't affected by anything. So we actually looked at individuals that did not have performance anxiety or any other anxiety disorder whatsoever, and we stressed them. We gave them the Trier stress test. It is a public speaking stressor. It is quite something, actually. You put them in a room and ask them to pretend they are applying for your law firm, and give an impromptu speech of why you should take them. Now, in the room, you have 3 panelists. The panelists are wearing a white coat, instructed not to smile or provide any other positive feedback, and take notes. So it's very stressful. And there's also a video camera on them, and they say that this is going to be recorded for future evaluation. And they also do a challenging calculation task at the end of the speech as well. So we added to the stress of this by interrupting them to solve some problems. And we gave them word unscrambling problems. You can see my icon here, like unscrambling those letters to form the word brick. They had to do that in a timed manner, and then they went back to their speaking task. We also gave them the compound remote associate test, where they had to find one word that formed a compound of the other three. So if I gave cone, apple, and tree, the solution is pine. So pine cone, pineapple, pine tree. And as you can see at the bottom here, the compound remote associates, they solved fewer when they were stressed, and also anagram solutions were slower when they were stressed. But if you gave propranolol, this completely reversed that effect. They reported feeling some stress, but the cognitive effect of stress was gone. This is very, very exciting. And these are, again, people with no stress history, no anxiety history. So there's something fundamental about how the pharmacology of stress and the adrenergic system functions in the human brain. We then went and looked again at healthy, unaffected individuals and dispensed with the stress component, but did a large study looking at task difficulty. And we found very similarly that if we just took the hardest problems, that propranolol caused people to solve the anagrams more quickly, significantly more quickly. And also, if we just took the tertile, the third of individuals who were just in general struggling the most, they also had a benefit. They solved more quickly with propranolol. If you took the easiest problems or just the people that were doing the easiest, there was no benefit and even a trend towards a worsening. And also, this crossover, just for what it's worth, happened in about a little over 3 seconds. If it took you longer than that, there tended to be a benefit. So there's something even outside of stress that's very, very fundamental about how propranolol affects cognitive processing. We're really excited about that. And one of the problems in the literature is that when you talk about cognitive flexibility and the pharmacology thereof, propranolol doesn't really come up because the literature focuses on tasks and the problem-solving tasks that cognitive flexibility that are actually a choice between two options. And so with these, you can find serotonergic, dopaminergic, and alpha adrenergic effects, but not beta adrenergic effects. And so examples of this is like reversal learning. And if you if you train a rodent, you can do similar things with people. If you train a rodent to find a treat after in one of two wells, they find it under the clove-smelling well, they can reverse that to now the nutmeg-smelling well is the one that has the treat. And how quickly do they learn this reversal? You could do an intradimensional shift in which they switch from determining between clove and nutmeg to now between rosemary and cinnamon, and you can do an extra dimensional shift which they switch entirely out of smell altogether and convert to digging material or the covering is velvet versus felt, and now that's the discriminatory thing they need to sort out. But in human problem solving and the things like the tasks we're doing, it's not a decision between two things and how you shift between them. It's looking for a more remote solution. So clearly there's an element that is missing with this paradigm. We took the very same task, with Pat Heck did this in our lab, so here are the two pots that would have the different smells in the old, the experiments, the set shifting tasks. So the smells or the textures over them. And we actually ran them through those very same paradigms on and off propranolol. But what we also did was we had a digging chamber. And they once had exposure to this well at the very end where they once had encountered a treat. And so what we did was on testing date, we covered this up in sawdust and blocked off the chamber while they did their regular set shifting tasks. And then at the very end of that experiment, we opened up the chamber and saw how they did when they were no longer getting rewards from these two side chambers. Did they figure out the more remote solution of digging through and going and finding the treat in the far end of the chamber? And what we found was quite remarkable. We found absolutely no effect of propranolol in any of those set shifting tasks, but about half of them did actually solve this task on propranolol, and almost none of them did without it, and this difference was significant. I'll give you an example of this. This may be a little, if you have a slow connection, this may be a little ratchety, but I'll walk you through what's going on. This is the placebo rat. You see that it's going to the wells where they previously had received a reward, and then it's entering that newly opened chamber, but it's blocked up by sawdust, and so they're not going there. And then they go fish around the other well eventually. Well, it's not there either, and they keep going back and forth. And while this is going on, I can explain, why we care about this. If you want to understand the mechanism of action, I mean, there are things you can't do, and a rodent model allows you to figure out what's the mechanism that's going on. And the big thing is that if you want to sort out maybe a slightly better pharmacological agent, you don't have to run immediately to people. You can test this out and say, oh no, okay, this subtype of variant of propranolol, this actually works just as well in this model, and we can begin to learn in a manner before we even have to test on any people what is going on and what else might work. So as you see, this rat just going back and forth. Now here is the propranolol rat. He does very similarly at first because there has been reward at these two areas before, and there's this new area open, and at first there's no benefit to going just straight into the chamber, and so he goes back and forth, but for a very high percentage of these guys would around half of them would actually manage to solve the problem. And I think he may be getting the hint that there's something going on here. I will pause for a second because it's kind of cool when he starts digging. And no, not yet, not yet. And here it goes. He's starting to dig right now. And there he goes. So this is a visual demonstration of what we did. So at that point, we had a mechanism, which is very, very exciting. We had a way to allow us to look at mechanism, which is very exciting, and test new agents. But after all this nice study in the clinical population and unaffected individuals, and also some data from the earlier case series in autism, we wanted to begin to look to see, does this help individuals with autism? And our initial little pilot study looked at the anagrams, and we took the easy anagrams, the ones that unaffected individuals will not benefit from. We did a single dose psychopharm challenge. We wanted to determine in the simplest manner possible what this drug might help. And so we counterbalanced it. Half of them took placebo first, half of them took propranolol first, so that there wasn't just the second time they did it, it was better. And what we did was we found that individuals with autism, autism spectrum disorder, were a little slower of the easy anagrams, but with propranolol, they actually perform quite well. These are, again, individuals with a normal IQ and very higher functioning individuals, so they're able to do these tasks, but they were a little slower, and propranolol actually brought them to within the control range, and the controls did not have any similar benefit. We later, upon moving to Missouri, got some pilot funding within the Thompson Center, and we looked at word fluency. Same single dose psychopharm challenge approach. We had 14 individuals and 14 controls. Now, category fluency is where you name as many animals as you can, and letter fluency is how many words do you think of that start with the letter F, A, or S. And individuals after propranolol, without propranolol, they came up with fewer words, but with propranolol, they actually brought them all the way within the range of the control group, which is very, very exciting. There's no effect on letter fluency. One might think that perhaps looking through categories has a broader impact of networks because it brings in the semantic and associative network, whereas letter fluency is typical, just lexical access. But that's hypothetical. We also, with the help of Sean Christ and Kim Bodner, who's now Kim Engelhardt, we did the AXCPT working memory task, where individuals were asked to respond to one button when they saw an A, followed by an X, but with a different button when there's any other combination. But the contextual situation is they respond when they see the X. So if the stimulus was a B, they have to use that context, and individuals with autism had struggled with that situation, but it improved significantly with propranolol. So it affected contextual working memory. And also, we looked at facial scanning. We wanted to begin to get into the social domain. Unfortunately, we had a very, again, higher functioning group who was able to do all these fancy other tasks. So we selected ourselves out of a significant effect between ASD and control on eye contact, which is unfortunate. They'd been receiving great therapy all along, and they had adapted on their own because they're really smart people. So there's no drug effect, but there's no group difference. But one little interesting thing is that mouth observation is somewhat atypical, and we did have a decrease in mouth, looking at the mouth with administration of propranolol. And this the mouth fixation may have been some salience because it correlated with the Autism Diagnostic Interview Revised Nonverbal Communication. So we wanted to look at how this is manifesting, and then get into some slightly larger trials that are a little better targeted. So one of the theories of autism is there's decreased central coherence. This may actually be represented with imaging studies. Functional MRI is a methodology that uses MRI that targets the BOLD sequence, the blood oxygen level dependent sequence. And with that, you can measure blood flow and blood oxygenation. So if you do a BOLD sequence when you're tapping your fingers, you will have greater activity detected. You'll have a greater signal in the motor area of the left hemisphere. And if you compare that to a rest scan and do a subtraction image, you have a difference map of what has been activated by doing that task. And you can overlay that on anatomical images, regular MRIs, and have a heat map of activation with your task. Very cool, very pretty pictures, and you can look at how those regions correlate with each other. And this is a bit of an simplification, but there's tends to be a local hyperconnectivity and global underconnectivity in individuals with autism spectrum disorder. Now, again, there's a lot of caveats to this, but in the original studies, when people did language or problem-solving tasks, the remote brain regions did tend to have decreased functional connectivity, the decreased correlation between those activated brain regions. And there's plenty of evidence of the semantic network being affected in autism. We had one example of that. That was our PNAS paper a number of years ago. And this may also be very important for the social domain. So we wanted to look to see, does propranolol affect this? And we took a task that was a word categorization task. So everybody performed very, very well in this task and got a rather typical language activation map. With this task, you could see what an fMRI might look like in its simplest representation. And individuals with autism and individuals without autism all performed well in this task. So there wasn't a factor of, well, the activation is decreased, so they just couldn't do it. So we had that accounted for and looked at the effect of propranolol on connectivity. And what we found was an increase in connectivity with propranolol. Now, this was compared to both placebo and also to natalol. And the reason we did that is you're looking at the blood oxygen level dependent sequence. So if you're decreasing heart rate and blood pressure, you may be spuriously affecting that signal just because you're lowering heart rate and blood pressure. So propranolol penetrates the brain. Natalol has exactly the same effect on heart rate and blood pressure by the same mechanism, but doesn't enter the brain. So that accounts for all those blood pressure and heart rate effects, and we found a significant difference there. And that was really exciting. At least goes with this semantic network effect maybe being related. Also, at resting state, we did a larger study more recently, as funded by HRSA, at resting state, it depended upon the network. It's a very complex relationship. So propranolol increased the left hemisphere medial temporal lobe subnetwork of the default mode network, and it decreased the prefrontal subnetwork of it. So when you're looking at resting state, it's a much more complicated picture that requires further investigation. But we wanted to do this with a little bit of a larger study, get a really a better handle on the social domain and its effects, propranolol's effects in autism, and also begin to look at the markers that we talked about earlier, subtyping on individuals with autism, which would be really, really important down the pike. Now, it's a little limited what you can do with a small group like 20, but we're growing here, as you can see, 9, 14, now 20. And again, these are higher functioning individuals, and we did the counterbalance testing, and it's a single dose cyclopharm challenge again. This time we did the general social outcome measure. Rachel Zamzo led this arm, Brad Ferguson helping out a lot. We chose 2 topics from a topic database. Janine Steischer developed this task, and this was the social reciprocity component from her test that was fully developed by the time we started the study. And it was rated on a scale of 0 to 2 across 6 domains: staying on topic when we presented the topic, sharing of information, reciprocity, transitions or interruptions, nonverbal communication, and eye contact. And so it's a 12-point scale, so we were hope we could find anything here, but we felt we really needed to look at the social domain with this medication. And lo and behold, we actually found a significant effect of the effect of propranolol, about a 1 point higher performance with propranolol in this counterbalance single dose cyclopharm challenge, which is very exciting. We also looked at the anagram task again while trying to target markers of treatment response. And what we found was quite interesting. The placebo, the solution latency was lower, as you can see with propranolol. The number solved, which is a much less sensitive measure, was unaffected. And we also looked at the psychophysiological markers, and we looked at heart rate variability, and 2 different measures of heart rate variability predicted the response to propranolol for solution latency, which is very exciting, as did separation anxiety score on an anxiety dispense scale. So this begins to give us a hint that this may be something of importance, that individuals with autism, there may be a subset of them that's most likely to respond to propranolol. That'll be important later. So I'm happy to say that in the past year we got funded to do a clinical trial from the Department of Defense. And with this study, our plan is to examine the effects of serial doses. Now we're going to do just like you would in the clinical setting. And our primary outcome measure was the social interaction. That's part of why we did the social outcome measure, is to figure out if that is something responsive to the agent. But we'll also secondarily look at language tasks, anxiety, adaptive behaviors, and global functioning in the high functioning group of adolescents in this same type of group that we've been studying before. Now, our second aim is also, it's going to be really important to know that this benefits people earlier in life, because the developmental cascade may be even more beneficial on them. So even though we haven't tested a younger group, this is going to be a really important arm to look at and to see if there's benefit. And of course, the second aim is to get at this individual response issue, and to see if the psychophysiological markers, skin conductance or heart rate variability, predict who's going to respond. We'll also look at the pupillary light reactivity with Gary Yao, who has an index that's one component of it is sensitive to the noradrenergic system, and also look at whether the connectivity and fMRI will also predict treatment response. So get a whole range of potential markers to get at this, to understand who is going to respond best, in addition to whether there is a response. Again, we'll have a similar criteria for inclusion: no other major neurological psychiatric conditions. You have to exclude people who can't tolerate imaging or can't tolerate the medication, and they have to be able to read the tasks they're supposed to do. There are going to be 2 groups of 40, one at the younger age 7 to 14, and one at age 15 to 24. Actually, that's a typo. It's correct on that one. I didn't correct it on this one. And they'll be confirmed diagnostically. We're going to look at the markers I mentioned earlier, including the anxiety at baseline based upon our previous evidence. The primary outcome measure will be the social outcome measure, in addition to all the other measures they'll be following along. And the dosing will start with a 40 milligram dose that we used with our single dose psychopharm challenges, and if as people tolerate, we'll titrate up to as much as 100 milligrams. And of course, the children would be weight adjusted for this to make sure that it's the same concentration that they would be getting. And this actual titration schedule has been used in a number of other populations and tolerated well. We'll be very, very cautious. Nobody needs to get to 100. If they tolerate better staying at 40, we'll leave it at 40. This is a 12-week trial for each individual. We'll test once at baseline and check in with them to make sure they're responding and make the adjustments. We'll check them in again at 6 weeks and also at 12 weeks. And the last 3 weeks are a taper of the medication. When they get to the full dose, they will have the option of an open label extension to continue on to see if this benefits the whole group and to allow people to try the drug even if they were in the placebo arm for this. And also, we've had a lot of interest in the relationship between stress and other factors. Brad Ferguson and our lab led a study with us that was done with Vanderbilt and Columbia University as well as Mass General, and a large study actually to look at how stress reactivity related to gastrointestinal issues. And we found that a number of psychophysiological markers of specifically heart rate variability that are related to the stress response were significantly related to the lower gastrointestinal tract score, which was predominantly constipation. And of interest, this was modified by the presence of anxiety. So those with anxiety were the ones that had the strongest relationship. And furthermore, in another paper by our same group, we found that the lower gastrointestinal score was also significantly related to the cortisol stress response. So there's definitely a significant relationship between stress reactivity and lower gastrointestinal, lower abdomen problems in autism, which is mostly constipation. And alongside of this, my postdoctoral fellow, Brad Ferguson, is leading a study to see if propranolol actually impacts this aspect and improves the constipation or any other aspect of this, which is, I think, a really excellent idea to expand this study into other directions. I tend to talk fast, so I do leave open a bit of time for questions, but this is a bit of a 10,000 foot view of what we've been doing with propranolol. I'd like to thank, before I go any further, the team. I absolutely could not remotely possibly have done this myself. Brad Ferguson, I mentioned, he is leading this. He was helping throughout all of the Missouri pieces of the study, and also is leading the gastrointestinal part that's already done and the one that's going on. Rachel Zamzo led the HRSA-funded 20 subject studies, and she actually is now a science journalist and wrote a really, really nice article in Atlantic Monthly that talks about heterogeneity and it's important for autism treatment. And it mentioned that our baclofen study. It's a really good read. I recommend it highly. Brad Ferguson is postdocing with me right now. John Hegarty did the imaging studies and is now postdoc at Stanford. Morgan and Emily helped out a lot. Steve Canny, this couldn't have been done without him. He's the head of the Thompson Center, and he and Micah Mazurek helped us a lot with the assessment side of things, as did Sean Christ, who also helped us with the imaging. Dean Steeser developed these tasks. Pat Hecht did the animal model test. And Ashley Hillier, and Ryan Smith were involved in many of the other projects earlier. The initial phases prior to the autism side of thing, I worked out the model with a K award from NINDS. We got the pilot imaging study was funded by the National Alliance for Autism Research before they all rolled into Autism Speaks. Autism Center pilot grants and emission enhancement funds got us started on our initial studies, and Health Resources and Service Administration funded the larger imaging and clinical single-dose challenges, and now the DoD study is funding our clinical trial. So we've made full use of all the different resources out there supporting autism research, and that's what you have to do these days. And finally, I'd like to thank our current DoD team. A lot of the folks from the previous team are part of this. Gary Yao with the pupillary response team, Kristen Soul helping Minsleuth recruitment, Greg Petrosky on the stats side, and our whole graduate student team. Many of them carryovers from the team before, along with Brad, as well as Brianna, Nitu, and Allison, and the Thompson Center Research Corps. Nicole, nothing could happen with any degree of effectiveness without Nicole's presence. Melissa and Julie, I am really looking forward to their involvement, and Bridget is our nurse, and she's fantastic. So with that, we're really excited to move forward. We're starting right now, actually, with this trial. And this is the last three pictures have been of our team and its various iterations over time. And to wrap up, I'd like to open it up to any questions.
Okay, well, we've got lots of questions. Hey, and I'm sorry about that little brief moment of feedback there. That was actually on my fault. That was the that was at my end. So, but I think we got through most of the talk really well.
That's not everybody's perception.
No, I think we're totally fine. So we do have some questions. I think the first big question I just got 15 times was, how do we get in a treatment trial?
Well, the interesting thing is we're actually registered through NIH, the clinicaltrials.gov, and you can go to the Thompson Center website. It's only at the Thompson Center. However, this drug is available generically. So if anybody wants to look at our protocol, they're welcome to, and you could actually try it on your own. I can't recommend that because it's not FDA approved for that purpose, but it is generally available, and so that is an option if somebody wishes to explore it. I do not profit from this drug in any way, shape, or form. It is pennies. It's dirt cheap. That's why there's no pharmaceutical industry support for this. So I don't have any dog in the race as far as that goes. I just wanted to see if that helps. And so so if you're in our area and want to look at it, you can go to the Thompson Center website and reach out to us. If you are elsewhere, the trial is available on clinicaltrials.gov, and one could consider discussing it with their physician, whether they wish to approach it. Now, there are lots of cautions, things you shouldn't take it if you have asthma, you shouldn't take it if you have active depression, the exclusion criteria are listed, you can't take it. So it's something to be taken with open eyes, but it is conceivable you could try it outside of the trial setting, just because it's already available for other purposes.
Okay, and so another question, I'm sort of kludging a bunch of questions together here, but a couple of months ago we had a talk where the researcher was speaking about serotonin's role. So does propranolol have a link to that? And you talked a little bit about the GI issues. I wonder about connections between those two things. How does propranolol impact serotonin? Or do we know?
Well, that's an interesting thing, because there is discussion that propranolol may have some effect on serotonin. So you can't be 100% sure that this is purely an adrenergic effect. No drug is pure. That's how it is. And so it is conceivable it could relate to serotonin. I'm wondering if this serotonin speaker was Jeremy Beanstra Vanderwill?
It was actually, it was Kara Margolis.
Oh, it's Kara Margolis. Okay, they work closely together.
Yep.
Kara's marvelous. So I can't tell you for sure this might not relate to serotonin at all. However, the relationship with the gut could also still be serotonin, or it could be adrenergic, because if you're affecting the stress physiology, it may be having downstream effects on the gut. They may or may not be related to the serotonergic system. So it's quite conceivable this could act through the serotonergic system. Its main effect, though, is adrenergic because of the very significant effects on heart rate and blood pressure. But it's not impossible. We can't exclude that possibility that it does relate to serotonin. But I'm thinking it probably doesn't. But that's something we may have to ultimately sort out in the future.
Okay, so getting off of that track into a different track, people are asking about, what are the side effects of using propranolol, and how does it affect blood pressure? Like, is daily use a concern? So what are some of the things that people might be thinking about if they're using it for a longer period?
Right. The single dose second challenge, you don't have too many issues because it does lower their heart rate and blood pressure significantly. Longer term, but it comes right back up. Longer term, a couple caveats to notice. Number one is it would, yes, it would lower your heart rate and blood pressure. That's why we're keeping an eye on it, making sure somebody doesn't drop too far. You don't want to take it if you're taking an alpha-2 agonist, because both of them act similarly on lowering blood pressure and can be highly synergistic, and that'd be bad. You can really bottom them out, and nobody wants to do that. And that's significant if somebody has, say, ADHD is taking guanfacine or clonidine. Those are the two drugs that we'd want to watch for. So you can't add it onto those two drugs. The other thing is with sustained taking it, you'd want to wean off of it slowly so you don't have a rebound in hypertension or increase in heart rate. There are a few things you want to watch for. Somebody who's hypothyroid might have a tendency to have lower heart rate, and then that could make it worse. Diabetics may not feel the effect of their low sugars when they take it. Asthmatics, it can worsen asthma. People with depression, it can worsen depression. There are a few other things to watch out for. Obviously, keep track of the heart rate and blood pressure if you may feel lightheaded. And also some people, sexual dysfunction can occur. They have trouble with performance issues with this medication. However, it is generally reasonably well tolerated outside of all those caveats, given that it's a fair number of them. Narrow angle glaucoma is another issue if you have that. So as with every drug, there are lots of things to watch out for, and that's why if somebody is interested in taking it, I would really not strongly, you have to go to your primary physician and discuss it with them and whether someone is appropriate for it. But again, I can't recommend this because we haven't done the trial yet. We have single dose psychopharm studies, but I understand everybody's desperate, and that's a conversation you can take on your own. It's not a recommendation. But that's why you need to speak to your physician, because there are a number of things you'd want to be careful for, to watch for, and reasons you wouldn't want to take it.
Okay, so another question. People have been asking if this is primarily, it sounds like it's primarily the benefits been observed in higher functioning individuals on the spectrum. Has there been a study where we've involved folks who aren't as high functioning, or would that just create difficulty for measurement? Is the theory that it might help anybody?
Let's hope. We believe in targeting the higher functioning individuals because we can hit them with a massive barrage of tests to really sort out that effect. It is about measurement. Now, at this stage, I think is a very reasonable thing to look at a lower functioning group. And I would think that that's an excellent idea. We really need to know that question and the answer to that question. But it's been looked at in higher functioning individuals because of how that's easier to do all this testing, and you can do some really fine-grained testing to sort out what effects it's having. But we do need to know the answer to that question. I don't have a reason to believe that it wouldn't work in lower functioning individuals, but this is inter-individual variability. It's extremely important to sort that out, and we would not have an answer to that just yet. We are doing a pilot trial to look to see if it benefits individuals as a very low dose add-on to their ABA program, because it's relatively low risk, and in fact, with used for infantile hemangiomas, a much higher dose. So actually know how it is tolerated in individuals at an even younger age. And so we're having a pilot study to explore that. E2's leading that. See if we can sort out a benefit in that population where we're taking something that actually does help people, and see if we can add to that. But again, the doses of that are lower, just to try to use it like test anxiety for the ABA therapy sessions.
Okay, so I think you went over this a little bit, but I've gotten quite a few questions about it, so I want to go over it again. Do the benefits conferred from propranolol extend to other cognitive domains? I know that we were focusing a bit on social skills, but were there overall benefits in that performance?
Well, language and social were discussed by the original study in 1987, the case series, and those are the targets of what we were doing. And we generally targeted those areas. We are going to ask that question now with the clinical trial. Now, there is a twist to the story that's of interest. There's another group who reported it recently in MFAR, Dr. London. He actually looked at behavior disturbances and took higher doses. And it does seem to have a significant benefit for that group as well. So there is that possibility as well. It's been used in a number of other clinical scenarios related to this, but like the test anxiety and such, but we don't know the answer to that question, and we hope to get the answer to that question in just a few years.
Okay. Is it addictive? Is propranolol a drug that they can be addicted to, or what's the half-life of the drug?
Well, the half-life of the drug is just a few hours. We 2 to 4 hours. 4 hours, you begin to see a decrease in the concentration. So there's a long-acting version which we would be able to use, which people can use, basically a slow-release version. So you could take the long-acting version, or you'd have to have repeated doses of the regular version. Now, it's not addictive per se, but you do want to wean off of it so you don't have rebound hypertension or rebound increased heart rate. So it's actually been used widely for other clinical syndromes. So we have a pretty good track record of its use. It's not a new drug that's mysterious in its effects.
Okay. All right. So another question, people are asking about other like natural things they can take that are similar to the effect that propranolol would have. Are there natural agents, or are you aware of anything that mocks the same?
Well, it's very hard to say, quite honestly. One might presume that biofeedback would have a similar effect or some kind of intervention such as that. As far as agents go, back in the original studies where we looked at people that did not have autism or anything, we try to sort out, when we looked at those effects of propranolol, we looked at other anxiolytics. They did not have that effect, benzodiazepines. And so it does seem to be somewhat specific to the beta-adrenergic receptors acting upon them. So I don't know what other nutraceuticals. There are a lot of anxiolytic type of nutraceuticals that are out there, but I don't know of any that target specifically beta-adrenergic receptors. A general calming may not have the same effect. So we don't know the answer to that question. I'd certainly be open to something that does, but the nice thing about this is it's past its patent long ago, and is now very inexpensive. So one is at least able to access it without great cost. So that's a plus, at least, even though it is prescription.
Okay. And would you expect other beta blockers to have similar benefits? So is there something special about propranolol, or are there others that you would think would do the same thing?
That's a really good question, actually. Here's the reason why this is not the simplest of answers. There's several different types of, there's cardioselective and agents. There's beta-1, beta-2 selective agents. There's agents that cross the blood-brain barrier and those that do not. We did compare in back in those early development phases, looking at the healthy individuals with no autism or anything. We compared a propranolol to nadolol, the same drug that's peripheral only, and propranolol was significantly better in performance than nadolol. So I strongly suspect that it would have to be central. We do not know whether the beta-1 or beta-2 component is acting here. And in fact, animal model studies have sorted out that beta-1 and beta-2 activation have very different effects on working memory. And so over time, that's why I was referring to the rodent model. One can begin to ask that question in the rodent model without involving people to sort out if it is beta-1, beta-2, or if it requires both to be active. But I would definitely think you would want to target a centrally acting agent, and propranolol does cross the blood-brain barrier quite nicely, but it blocks both beta-1 and beta-2 receptors.
Okay. All right. Another question is, so after its half-life, after it's worn off, does the effect go away. So is it only of use when you're taking it, or is there a longer term, do we suspect that there might be longer term benefit even after we stop using it?
The simple answer is no, but that's not maybe the whole story. So if you have test anxiety, you take it, and you took a test the next day, you probably don't have much benefit. However, people have been using this for anxiety, for situational anxieties, like incredible fear of spiders, and actually been able to reverse that effect. So it's conceivable there could be some effect, although we have no evidence to support that there would be for the kind of cognitive things we're looking at. But the hope is that maybe with a slight anxiolytic helping people get through therapy sessions or schooling, you've improved the cognitive milieu, and it would benefit them long term as well, more because their environment for learning is better with the better cognitive performance. That's extraordinarily speculative and would require data to back that up, of which I have none. So it's a very good question that I can't answer.
Okay. So another question here, people are just asking about, you've said that it's past patent and then it's fairly inexpensive. I think I know the answer to this question, but I think what you're saying though is that they need a prescription. So they need to work with a medical doctor to discuss it.
That is correct. And because of the risks and side effects I talked about, it's not something, there's certain patients that shouldn't take it or should be closely watched.
Okay, so if they're interested in it and they want dosing information or any specifics like that, they would need to contact a qualified medical provider to get full support.
Right.
Right. That's not something that we can do on a webinar just because you'd need to see a patient to do that. So one thing, I've had this question, it's an interesting question. First, this person is asking at what age it would be safe to use it for a child if that's established. So if there's too young an age for it or if it matters. And then the next question is, in determining that, would physicians look at, when they're looking at the whole case, do they consider sort of the overall health of the child and what would be some factors that might sway them one way or the other?
Well, the risk factors I talked about earlier would be the ones that would sway you away. Cardiomyopathy might be a reason not to, some severe cardiac disease, a person with a very low heart rate or low blood pressure, but that's in addition to all the things they're listed in our on our exclusion criteria as well. Things that would make you not want to take it. As far as whether there's an age that's too young, we don't know for sure long-term effects of whether this is going to have long-term help or if it dulls people somehow and causes trouble in learning. I don't think that it would do that, but we don't know what its effects are long term, and that's where we're going to need to get some answers. We could definitely look at short-term effects, and we're going to get those answers sooner. And we hope to get the answers to the other in the near future as well. But so as far as doing it, as far as medically safe at an early age, we do know that it is tolerated as infants because it's been used for infantile hemangioma in even higher doses. So as far as safety goes, that's it. We do not have data to tell us one way or the other if it's going to be beneficial, though. That's why we're doing the study.
Okay, and part of the profiling that you're doing when you're selecting patients, are you looking specifically for families that have a history of high blood pressure or other hypertension? No, so you're not selecting that way, just based on the autism diagnosis. Okay, so the family, right? Okay, great. All right, and one more question. I know you've talked about this a little bit. So if people want to look at drugs that are contraindicated so they make sure they're not mixing things that shouldn't go together, like guanfacine, as you mentioned, where can they find that information if they want to look online?
Probably there's a number of websites that link to the patient the interaction sheets for propranolol, but that's another good reason to speak to your physician, because they will have access to that information too. And propranolol is used for enough other conditions that most doctors are reasonably comfortable with its use, and they're going to know what you can and can't take it with.